I'm honored to be speaking to all of you today about vaccine-induced immune thrombotic thrombocytopenia following vaccination with adenoviral vector COVID-19 vaccines. And today I'm going to focus on generalizable learnings and future implications. I have no conflicts of interest to disclose. Today we're going to discuss the clinical presentation and pathophysiology of VITT. We're going to get comfortable with its diagnosis and treatment, and we're going to put VITT in the larger context of other catastrophic thrombosis syndromes. But let's start with some recent history. So the beginning of 2021, after nearly 10 months of a global pandemic with lockdowns, overwhelmed healthcare systems, and a terrible loss of life, we finally had a ray of hope. Vaccines had arrived, and with them, the promise that this pandemic might come to an end. But then in March, shadows appeared on the horizon. A healthy 49-year-old Austrian woman received the AstraZeneca COVID-19 vaccine as part of her country's initial rollout to healthcare workers. Within 10 days of vaccination, she developed cerebral sinus vein thrombosis, pulmonary embolism, thrombocytopenia, and disseminated intravascular coagulation. Her platelet count was only 18, and her D-dimer level was over 70 times the upper limit of normal. She tested negative for COVID-19. The patient received a platelet transfusion and started heparin anticoagulation, but she got progressively worse overnight. She developed extending splenic thrombosis and bowel ischemia, and she was dead within 24 hours of hospital admission. Her blood samples were sent to Dr. Andreas Greiniker in Germany, who tested the patient for heparin-induced thrombocytopenia. He found that the ELISA for anti-PF4 antibodies, which we do see in HIT, was strongly positive. So this raises the question, could this be heparin-induced thrombocytopenia? But the platelet activation assay, which is positive in classic HIT, was negative. When heparin was added, it was still negative. But when PF4 was added, all of a sudden the platelet activation assay became positive. This is actually the first published case of VITT. VITT is a newly described syndrome with three key features. First, patients have blood clots, generally in unusual sites like the cerebral veins or the portal circulation. They also have thrombocytopenia, usually quite significant thrombocytopenia. And though patients are generally healthy before they present, up to 40% pass away. The syndrome's onset is really stereotyped. It shows up between 5 and 28 days following vaccination. As you're going to see in a few slides, this time frame gives us an important clue as to what is behind it. Now, when VITT was initially reported in Europe and North America, there was a suspicion that females are particularly at risk, but this was likely an artifact. Most early AstraZeneca vaccine recipients were actually healthcare workers, and most healthcare workers are female. The gender breakdown is actually pretty even. Now, there might be a slightly increased risk in middle age, but we've seen patients present at all ages. And importantly, there are no clear risk factors. So there's nothing about a patient that would put them at particular risk. The platelet count is a really important clue in VITT. In reported cases worldwide, it ranges between 10 and 110. But at diagnosis, the median platelet count that you would expect is about 40. Now, of course, many other conditions can cause low platelets. We'll talk about them in a moment. But we know that the platelet count in VITT tends to be higher than immune thrombocytopenia, ITP, or drug-induced immune thrombocytopenia, DITP. It also tends to run a little lower than classic HIT. VITT is also accompanied by DIC, which I will expand on shortly. The clots in VITT can be seen anywhere. CSVT and portal vein clots get a lot of press, but a fair number of patients have DVTs and PEs as well. Many have arterial clots, including acute limb ischemia and heart attacks, and many have clots at multiple sites. In fact, on autopsy studies, nearly all patients have more widespread thrombosis than was clinically suspected or was confirmed by imaging. And there's clear evidence of microvascular thrombosis in multiple organs. Now, when we treated our first patient with VITT in Hamilton, I remember one of the ICU residents commented to me, well, you know, there's thrombosis, and then there's thrombosis. And this sentiment, it really was quite insightful because there's something about these VITT patients, the widespread, aggressive, unrelenting nature of their clots that is a huge red flag. But VITT is not the only condition that does this. So I think we should view VITT as part of a larger family of catastrophic thrombosis syndromes. Now, it's often said that the main syndrome to be distinguished from VITT is ITP. But ITP is not associated with this rapid onset of clots affecting arterial and venous and microvascular beds. But there are other diseases that do this, like thrombotic thrombocytopenic purpura, or TTP, catastrophic antiphospholipid syndrome, or CAPS, cancer-associated thrombosis, or CAT, and the very close cousin of VITT, heparin-induced thrombocytopenia, or HIT. So I'm going to walk you through these diseases. All of them are quite rare. All of them are highly morbid. Like VITT, the clots in these conditions tend to occur simultaneously or within days to weeks. Thrombosis frequently involves unusual sites, and treatment can be really challenging because there's often a concomitant hemorrhage. For example, when you have a CSVT, that causes back pressure in the circulation that leads to intracranial hemorrhage. Many of these patients have hemorrhagic risk factors like thrombocytopenia and DIC. So recognizing these entities, treating them proactively can be very life-saving. So let's take a quick detour and walk through these conditions. The first catastrophic thrombotic syndrome I want you to know about is CAPS. So antiphospholipid syndrome is defined as the combination of venous or arterial thrombotic events and or recurrent pregnancy morbidity. And there's an association with persistent antiphospholipid antibodies. There's a catastrophic variant of APS, extraordinarily rare, where patients present with multiple vascular occlusive events over a short period. You can see venous thrombosis and arterial clots, but CAPS really predominantly affects the small vessels. Now, like VITT, you will often see low platelets and DIC in CAPS, but you may also see red cell fragmentation, which is not a feature of VITT. And of course, to make this diagnosis, you have to confirm the presence of these antiphospholipid antibodies. The initial therapy is also similar to VITT. We use anticoagulation. You can use heparin or non-heparin, either is okay. We do plasma exchange to remove the antibodies and corticosteroids to put out that immune fire. Acquired TTP is an immune-mediated deficiency of the von Willebrand factor-cleaving protease, ADAMTS13. When this protease is decreased or absent, you get unrestrained adhesion of von Willebrand factor multimers to platelets. So this can activate the platelets and cause microthrombosis, thrombocytopenia, and hemolytic anemia. Now, venous clots are quite rare in TTP, but in addition to thrombocytopenia, you're going to see the hallmark microangiopathic hemolytic anemia, or MAHA, with red cell fragments. And the diagnosis is supported by finding a decreased ADAMTS13 level. Now, the essential initial therapy is plasma exchange to remove the von Willebrand factor multimers and replete some of the ADAMTS13 that's missing. You can also use caplacizumab, an anti-von Willebrand factor agent, which inhibits the interaction between the multimers and the platelets. Now, an important treatment comparison with VITT is that in TTP, blood thinners are not used. Now, approximately 4 to 20% of cancer patients will experience thrombosis at some stage. And cancer-associated thrombosis has the potential to be progressive and recurrent, even if you give appropriate anticoagulation. So one example of a more catastrophic type of cancer-associated thrombosis is Trousseau syndrome, which is basically migratory thrombotic events. They can occur in the deep or the superficial veins. They can occur in the arteries. They can even affect the heart valves, which we call morantic endocarditis. And of course, there's always this association with an underlying malignancy. Trousseau syndrome has been associated with venous limb gangrene in patients with cancer and thrombosis, similar to patients with HIT. Now, cancer itself can cause DIC and thrombocytopenia, so that can make it hard to make the diagnosis of cancer-associated thrombosis. It can certainly make treatment harder. The primary treatment of patients with cancer-associated thrombosis consists of anticoagulant therapy, but patients who have multiple, particularly recurrent events, might benefit from an increased dose of anticoagulation with concomitant anti-factor Xa levels. The final catastrophic thrombotic syndrome that can mimic VITT is HIT. Now, classically, HIT is associated with proximate heparin therapy. That's the trigger. But it can also occur without proximate heparin. And putatively, that happens when other cations replace heparin and act as a trigger for this autoimmune phenomenon. Now, HIT is rare, but it's not quite as rare as you might think. So it occurs in 0.1 to 5% of patients receiving therapeutic doses of heparin. These are the folks who will develop anti-PF4 antibodies, but not all of these antibodies clinically manifest. It's really important to think of HIT as sort of the tip of an iceberg, where only the top of that iceberg actually suffers from clinically evident thrombocytopenia and clots. HIT presents with macrovascular thrombosis and thrombocytopenia. The microvasculature can also be affected. It occurs usually around 5 to 10 days post heparin exposure, but can occur up to 30 days after. Like VITT, we see anti-PF4 antibodies, but their ability to activate platelets is not inhibited by the addition of heparin. The treatment is very, very similar to VITT, and I'm going to dig into that a little bit further in a moment. So the coagulation activation that happens in VITT and HIT are really similar. And in fact, this is not a diagram of VITT's pathophysiology. It's actually a diagram of HIT. In HIT, some patients who receive heparin develop antibodies to a complex of heparin and platelet factor 4. Platelet factor 4 is a small positively charged molecule that usually sits inside the alpha granules of platelets. These antibodies to the PF4 heparin complex stick to platelets. They activate them via their FC or IgG receptors. And when these platelets get switched on, they start to stick together and a coagulation storm begins. There's activation of other cellular components of coagulation as well, monocytes and neutrophils. The platelet count starts to fall as activated platelets are rapidly cleared from circulation, and blood clots start to form in venous or arterial territories. Now remember, in VITT, there is no heparin in the mix. Patients have not received it prior to developing this syndrome, and there is absolutely no heparin in the vaccine. But we see antibodies that have developed to platelet factor 4 and some novel polyanion. And the end result, this coagulation storm with activated platelets and cellular mediators of thrombosis and detectable antibodies, is really exactly the same. Now, there's been a lot of speculation about what, if not heparin, actually triggers VITT. So at least 2 research groups have independently found that the hexon protein on the adenoviral vaccine's capsid can bind PF4. And this is a picture of PF4 here. Again, it's a cationic protein, positively charged, that can form complexes with IgG. So when you have this novel antigen that's formed, it's taken up by monocytes and it's trafficked to lymph nodes. And there it stimulates proliferation of anti-PF4 memory B cells. We are all born with these preformed B cells. Other vaccine components, for example, EDTA or other human proteins in the vaccine, could promote a pro-inflammatory milieu that potentiates the immune response, that makes it more likely for these pathological antibodies to form. A recent paper out of McMaster University used alanine scanning mutagenesis and determined that the binding of VITT antibodies is actually quite distinct from HIT antibodies. So VITT patients' antibodies appear to bind to an area of 8 surface amino acids, all located within the heparin binding site of PF4. This might explain why we see VITT antibody binding in PF4 enzyme immunoassays is inhibited by heparin, just as I demonstrated in that case study that I showed at the start of this talk. Now, VITT, like all catastrophic thrombosis syndromes, can be sorted out if you just start with the basics. So start with the CBC to look for thrombocytopenia, take a good clinical history to figure out when the vaccine was given. Then move on to more advanced tests like the D-dimer, the blood film, and imaging. So VITT appears to be associated with systemic coagulation activation. When fibrinogen is converted into fibrin, clots are laid down and then they get broken up. The D-dimer is a breakdown product of fibrin, and in VITT you should see very impressive D-dimer elevations. Now the blood film is important because of what it doesn't show. In VITT, we only see thrombocytopenia. We don't see, for example, red cell fragmentation. So these blue circled red cells are schistocytes or red cell fragments. You should not be seeing them in VITT. This is actually a blood film of another strongly procoagulant condition, TTP, which of course is associated with microangiopathic hemolytic anemia. Now, imaging is required to diagnose a thrombosis. I won't get too in the weeds here, but basically, if you suspect a cerebral sinus vein thrombosis, a non-contrast CT head is not sensitive enough to rule it out, especially in a patient who has other clinical features of VITT. It's a great first step. If a patient presents with unusual neurologic symptoms in the emerge, we order it quite frequently. However, to really figure out if you have a cerebral sinus or vein thrombosis, you need to move on to either a CT venogram or an MR venogram. It really depends on what's most available and most practical in your site. Because we know that so many of these patients have additional clots that we don't even pick up on the initial scan, you should consider empiric ultrasounds. So do an abdo ultrasound to look for that occult splanchnic thrombosis before bowel ischemia develops. Do a leg ultrasound to see if you have DVTs. And it's also important to remember that not all VITT patients present with clots. So we've now had a few case reports globally of patients who present early in their disease and they're caught with the thrombocytopenia and the typical time frame and the vaccine history, but they haven't yet had a chance to clot. These patients should also be treated with anticoagulation to stop the process in its tracks. Now, the testing for VITT is again very similar to its close cousin HIT. In nearly every patient with VITT, we see high levels of anti-PF4 antibodies. You must use an enzyme-linked immunoassay or ELISA to detect these antibodies. We have rapid assays for HIT that are not ELISA-based, but they use different antigenic targets, so they're just not sensitive enough in VITT. That is, they can give you false negative results. Now, of course, the HIT ELISA is a very sensitive screening test for VITT, but we confirm it using a functional assay. And again, this is a graphic from a paper on HIT, not VITT, but it kind of illustrates the point. When you add VITT patient serum to radiolabeled platelets, the antibodies are capable of activating the platelets, turning them on, and making them spit out radioactive serotonin. And of course, in VITT, this release can be inhibited when you add heparin to the mix. It can be enhanced if you add more PF4. Now, once you suspect VITT, it's so important to begin treatment. And the treatment really builds on what we know of HIT management. And it's really a tripartite. It's prevention of thrombosis, shutting off the immune response, and supportive care for the clot. The key to anticoagulation is to preferentially avoid heparin and avoid platelet transfusions. Now, the theory is that those could add fuel to the prothrombotic fire. And back in the spring, our worry with heparin is that it might really enhance that antibody-mediated platelet activation. And this is certainly true of HIT. You should not be treating patients with HIT with heparin. But these days, we're less sure if that advice actually applies to VITT. Now that we know that those VITT antibodies actually competitively bind PF4 and block heparin, heparin might be safe to use, especially if that's all you have, which in some resource-constrained settings is true. Now, luckily in Canada, we often do have other options, so I suggest you use them. We suggest that first-line anticoagulation be a direct oral 10A inhibitor at full treatment doses. If the patient is too unstable or if renal function is impaired, you can consider parenteral fondaparinux, or you can use a direct thrombin inhibitor like argatroban. Administration of IVIG is the next really essential step. IVIG works for two reasons. It likely impedes antibody-mediated clearance of platelets, so it can raise the counts, and it can impede platelet activation because it blocks platelet Fc receptors, and it kind of extinguishes the thrombogenic state. Now, again, this is a sort of strong allusion to autoimmune HIT and the other catastrophic immune thrombotic states. In these cases, just giving blood thinners alone does not rapidly de-escalate hypercoagulability. Those prothrombotic antibodies can persist and keep being bad actors. Now, there's been some really great work from Canadian colleagues around plasma exchange and refractory VITT, if the IVIG doesn't work. We've also used steroids and rituximab if that fails, but our experience is limited and we're still not really certain how well they work. Now, the final aspect of VITT treatment, just like treatment of our other catastrophic syndromes, is managing the thrombosis. Now, I would say clinically that the most challenging complication of VITT is when you have bleeding as a consequence of thrombosis. So I gave the example of cerebral sinus vein thrombosis, where you can have intracranial hemorrhage, sometimes as the presenting symptom. Patients with splanchnic vein thrombosis can develop bowel ischemia and bleeding as well. And this is where anticoagulation gets really, really tricky. So my practice with cerebral sinus vein thrombosis, which will be discussed in another talk by my colleague Thalia Field during this event, is to push on, especially if I think the intracranial hemorrhage is due to back pressure from the clots. So I'm a big proponent of anticoagulating aggressively. And of course, if you're dealing with a bleeding patient who's clotting too, try to correct what you can and pull in broad expertise of colleagues. So give transfusions to correct hypofibrinogenemia, consider decompressive craniectomy if intracranial pressure is raised, add on anticonvulsant agents if there's seizures. Make sure you involve your stroke neurologist and your neurosurgeon. Now, VITT can present with some really frightening phenomena in addition to intracranial hemorrhage. As I said, we've seen bowel ischemia, adrenal hemorrhage, acute limb ischemia. And like all those catastrophic thrombotic syndromes, you're going to find yourself walking that line between bleeding and clotting, which can be really, really stressful. Now, one of the most common questions I get about VITT from Canadian physicians is, can we forget about VITT now since we're no longer using the AstraZeneca vaccine? Well, it's a good question. And the answer is, well, we probably can. We probably can. The incidence of VITT in Canada has been established at 1 per 55,000 first doses. And we know from our colleagues in the UK who have pushed on with AstraZeneca that the risk after a second dose is far, far lower. The incidence of VITT with the Janssen vaccine, which has actually been approved in Canada and we suspect will likely be rolled out in the coming months in some provinces, that risk is also pretty low. So about 1 in 583,000 folks who get the Janssen vaccine will develop VITT. There have been no confirmed cases of VITT with the Pfizer vaccine, and just one case report of VITT with Moderna. And that's actually an unconfirmed case report, which seemed somewhat more consistent with autoimmune HIT. So in countries like ours, which have the privilege of really largely pivoting towards mRNA vaccines, VITT is less of a concern. The learnings that we can apply to other catastrophic thrombotic syndromes are still important, but this specific condition seems to be falling off the radar. But at the same time, context matters. It's very challenging to forget about VITT on a global scale because adenoviral vector vaccines will continue to be used globally, and for good reason, because actually their benefits do outweigh their risks. So many questions have stemmed from the story of VITT. A lot of those questions are specific to low and middle income countries, which, as I said, will continue to use vaccines like AstraZeneca's. Access to anticoagulants and IVIG in these countries is limited. So we really have to figure out what the role of heparin is. Is it a safe alternative? Can we make DOACs more accessible to these countries so they can be a reasonable heparin substitute? And if patients can't access IVIG, for example, could steroids work? But if we look beyond VITT into the broader context, how can we enhance reporting and surveillance for adverse events of vaccination in these under-resourced settings? It's really kind of miraculous that the story of VITT was figured out so quickly when it was first discovered in March. But that was really a product of robust global vaccine surveillance systems. It was really a product of robust scientific cooperation. So how can we foster that infrastructure globally, especially in low and middle income settings? And for those of us in any setting, there's a lot of questions about what happens when VITT is over. So in Ontario to date, there have been 16 confirmed cases of VITT, and these patients continue to challenge our understanding. Their antibodies seem to persist for months. Some of them seem capable of destroying platelets long after the acute coagulation storm is over. Now, we're telling our patients that we think we need to anticoagulate for at least 6 months, but we're not sure what to do beyond then. Now, we also have decisions around stopping, which include, do we stop cold turkey, or do we shift these patients to secondary low-dose prophylaxis? And the implications of subsequent doses of vaccination are important too. Now, again, we're lucky in Canada. All of our patients are being boosted with mRNA vaccines, but patients are asking really good questions like, what might happen if I'm infected with an adenovirus in the future? Could it cause a flare of my VITT? And we really don't know. And I think, most importantly, I really think we need to ask ourselves as a medical community, how do we discuss vaccine adverse events like VITT candidly and transparently while still maintaining trust in vaccines? Now, sadly, reports of VITT, and to some extent, the policy responses to VITT, really poisoned the already muddy well of vaccine acceptance. We can't brush serious adverse events like VITT under the rug, but we really have to message clearly that the benefits of COVID vaccines far outweigh the risks. So this is really the larger public health challenge that goes far beyond the world of thrombosis medicine. So that brings my talk to a close. I'm going to leave you with a photo of my hometown, Hamilton, Ontario. I thank you all for your time today. I thank you for your ongoing support of Thrombosis Canada. And thank you for all that you're doing to help your communities through this pandemic.